Our next topic is navigating different regulatory regimes and value systems across countries. Joining Dr. Zach Kohani are Dr. Rebecca Brendel, Director of the Harvard Medical School Center for Bioethics and Associate Professor of Psychiatry, Jonathan Ketchum, Chief Healthcare Economist, the Council of Economic Advisors within the Executive Office of the President, Nikhil Sani, Partner at McKinsey & Company, Dr. Chetan Sarabu, Director of Clinical Innovation at Health Tech Hub, and Susan Wolf, Presidential Professor of Law, Medicine, and Public Policy at the University of Minnesota.
In this segment, our speakers will give short talks followed by a conversation, and we invite our audience to send in their questions. We will begin with Becca.
Thanks for having me here today. I'm really excited to share a few of my thoughts through the lens of medical ethics on how we can regulate AI and think about values across domains and across countries so that we can ultimately improve health and patient care. I want to talk a little bit about this, though, really from the perspective of what regulatory regimes have done so far, because what we've really done is focused on the AI separate from the doctor and the patient. Specifically, is this AI trustworthy? Can we trust the outcomes? How is it built? What data is it trained on? Are there particular biases? How does it perform? How do we monitor? And who might be harmed? In what circumstances? And who bears that responsibility? I want to encourage us today to really broaden our lens and to go from a place where we're looking at a doctor-patient dyad to think about how technology can help us transform that into a doctor-patient AI triad, and think about the opportunities for enabling regulation to do our best work, how these relationships can grow and change and improve both the nature of the human relationships, the nature of the relationships between human and machine, and ultimately the health of those who we care for. So how do we do that? I think this is just a huge opportunity. And the first area that's ripe for looking at is really our relationship as physicians to the AI and how we're using the AI. What do physicians need to know? What is digital literacy and fluency in using these systems? What do we need to create the kinds of environments where physicians are using AI well in the interest of our patients? Where are the places that we might run into trouble? And how can we continue to learn? And in these situations, regulatory frameworks can help us be our best selves. They can help us develop the environments and the circumstances in which we interact with AI and also interact with our patients. The second area is really at the level of the patient. So when we think about what AI can do here, we really need to listen and understand the way our patients are using AI and bringing it into our consulting rooms and into our conversations. So one of the major things that's happened just with digitizing and the information revolution, and now with AI, is this major democratizing of access to information that patients have. Now it's not just the journals, but they're seeing medical records in real time. That hasn't been a possibility up until recent years. These medical records used to be locked in file cabinets, and now patients are enablers of being able to review their information, make sure it's accurate, and engage information about themselves with information in the world through AI and other tools. But if we do understand this, of course, there are risks, and we all worry about those risks when patients come in with their own diagnoses, when they're using information that some might contend is in open access AI that is based largely on not well curated information from the internet, for example. What there really is now is the ability to have more information and have patients really be part of making better decisions and engaging in their treatment actively towards better health outcomes. And when the physician and the patient together are able to bring the AI into the conversation and into ultimately the patient's treatment, we'll be able to find positive ways to ensure that we have the same trust and the same responsibility fulfilled by physicians that also brings the patient's voice, preferences, and learning into that conversation. So what I want to do is really think about the ways that we can use regulatory schema and regulatory structures to help center these new opportunities to improve care and outcomes for our patients and to improve the nature of the relationship between physician and patient and AI in the care of our patients. And I really look forward to the conversation ahead about how we might do that together. Thanks so much.
Hey, it's great to be with you today. I need to start with the standard disclaimer that my opinions are my own and don't necessarily reflect those of the administration. The central claim that I want to make today is this, that predictive AI capable of improving treatment allocation functions as a multiplier on the return on investment of the therapies that it guides. Clinical decision science has long recognized that treatment value varies across patients. When baseline risk and treatment response differ substantially, the value that we realize from a therapy depends on how precisely we allocate it. Yet the evidentiary standards that we use to approve therapies, the payment structures that determine who bears the financial risk, and the regulatory pathways that govern continuous improvement don't consistently reward or enable that precision. I'll start by describing two mechanisms by which predictive AI can enhance the ROI of the therapies that it guides. First is risk-based targeting. If we can equip physicians to focus treatment on patients with higher baseline risk of the outcome that we're trying to prevent, we lower the effective number needed to treat the NNT. Second is response-based targeting. When treatment effects are heterogeneous and we can identify patients that are more likely to respond or respond with bigger effects, the average effectiveness among treated patients exceeds what population-level trials would suggest. Both of these mechanisms increase the ROI of the therapy per patient treated, reduce low-value care, and strengthen incentives to develop therapies for well-defined patient subgroups. What distinguishes contemporary predictive AI models is their capacity to integrate high-dimensional data across clinical, biomarker, imaging, and administrative domains simultaneously to generate predictions with greater sensitivity and specificity than prior rule-based or single-domain approaches could achieve. But my argument is about something that the existing literature doesn't address, namely the economic consequences of treating predictive AI as an ROI multiplier. This framing has direct implications for how therapies are developed, regulated, priced, and covered, and for how we evaluate the AI systems themselves. I'll illustrate this with two examples. First is the approach taken by one Medicare Advantage plan reports about its operations. Alignment Health serves about 275,000 seniors across 5 states. They built a platform called AVA that stratifies their member population into risk categories using real-time data integration. That risk stratification determines which members enter what they call their Care Anywhere program. Here's the distribution that drives their model. 74% of their members are classified as healthy and account for just 5% of hospital and facility spending. But 12% fall into the high-risk chronic category, drive 74% of those spending. The average alignment beneficiary receives about 5 primary care visits per year, but those that are identified at high risk and enrolled in Care Anywhere receive an estimated 24 clinical touchpoints through home visits, virtual check-ins, and care coordination. And Alignment's numbers that I haven't tested for myself report that emergency room visit rates for seniors with 6 or more chronic conditions are 52% lower than Medicare fee-for-service benchmarks, and overall they report 30% fewer inpatient admissions and 35% fewer ER visits compared to traditional Medicare in those same markets. Now, this is self-reported data. I haven't verified these claims, but it does illustrate the mechanisms in action. We concentrate interventions where baseline risk is highest, effective NNT drops, and ROI per treated patient increases. Critically, Alignment is operating under risk-bearing payment arrangements that allow them to capture the returns from the value that they create. The second example that I'll give shows why this matters for therapy development and not simply deployment. Eli Lilly's donanemab demonstrates modest slowing of cognitive decline in early Alzheimer's disease, but their highest stakes bet is their ongoing Trailblazer ALZ 3 trial, which is testing whether the drug can prevent progression to symptomatic disease in people with preclinical Alzheimer's, essentially trying a new prevention strategy for this terrible disease. Here, the ROI problem that the strategy faces is large. Treating preclinical Alzheimer's means that baseline progression risk over any relevant time frame is much lower than treating symptomatic disease. Effective numbers needed to treat are much higher. While the economic case hinges on pricing and the cost of delivery, it also depends on how well providers can identify the subset at high risk of progression who are also likely to respond. Blood biomarkers like plasma p-tau217 enable detection at scale, but detection alone doesn't solve the allocation problem. Among people with elevated biomarkers, who progresses quickly enough to justify early intervention? Who responds well enough? Who faces manageable safety risks? All else equal, Lilly's prevention strategy will generate a higher ROA the better a predictive AI model performs relative to existing metrics, including these new biomarkers. This can be achieved by AI's ability to generate predictive index measures that integrate neuroimaging, genetic risk, cognitive trajectories, and administrative data. So those are my two examples. 3 implications follow. First is for therapy evaluation. As predictive models guide trial design on one hand and real-world deployment of therapies on the other, efficacy estimates from broad trial populations may diverge even further from how they are used in practice. And this strengthens the case for FDA, payers, and providers to evaluate therapies using real-world evidence over clinical trial results. Second is for coverage and pricing. Precision targeting raises the per-patient ROI, but reduces the total addressable markets, the TAM, of new therapies. Value is concentrated among well-defined subgroups. Coverage and pricing decisions need to account for that concentration. This, in turn, will guide R&D decisions for new therapies. Third is for AI evaluation itself. A predictive model's value is derived. It depends on the ROI that the model unlocks for the therapies that it guides. And as a result, models should be evaluated based on allocative outcomes, not statistical performance metrics alone. The shift in framing to view predictive AI as an ROI multiplier matters for how we develop therapies, regulate them, structure payment to reward better allocation, and evaluate the AI systems themselves. Thanks a lot, and I look forward to the discussion.
Glad to be here today. As we kick off, I wanted to share 3 thoughts. First, I wanted to share some ideas on the potential savings of AI in healthcare. We have not realized these savings, unlike in other industries so far in the US economy, but I think it's important to understand the potential AI could have. In a forthcoming article with my co-authors, we've estimated that the total savings could be somewhere between $400 and $750 million, of which half is created by Gen AI-led use cases. What's important to recognize about this number is there's administrative spending and medical spending. On the administrative side, which is roughly $1 trillion in the US healthcare system, the savings would represent a 10 to 20% reduction of those dollars. On the medical side, though, which is 2/3 of the savings, this would represent 5 to 10% of the medical spend. While these numbers are different, they are important because they're different ways to capture the value, but it leads to another question about where will these savings go? While we've estimated this as net savings across the entire industry, that does not mean that this will actually result in lower healthcare spending. For example, the incentives might work that the hospital will recapture some of these savings and reinvest them into other parts of care delivery, and therefore they will not be represented in overall spending. This leads to a second point. How will these savings actually be implemented? When we've started working with organizations recently in implementing AI, we have learned that while half the savings come from the technology, half of this is from workflow redesign. In many ways, healthcare has not gone through the same process redesign transformation that we have seen in other industries, and therefore this is ripe to actually leapfrog with the use of AI. For example, take radiologists. One health system we've been working with, at 8 p.m. at night, there's no one there, but the machine's still working and taking scans for the radiologist to see in the morning. Traditionally, they do a FIFO model, first in, first out. So when the radiologist comes in at 8 a.m., they see the scan that was done at 8:05 p.m. and then 8:10 p.m. But by implementing AI, they actually are able to scan those, find the 4 to 5 urgent cases, and put those at the top of the queue first thing in the morning for the radiologist. This leads to better patient care and also doesn't affect the radiologist's workflow. And that's quite important, thinking about how to integrate AI into everyday life so that it feels natural. We have found it's critical to actually seeing these savings be realized. Which brings me to the last point. I want to raise with you why we think this time is going to be different. When the Affordable Care Act passed in 2010, there was a lot of discussion about electronic health records, and meaningful use created a ton of adoption of EHRs across the healthcare system. We could still argue today we haven't seen the productivity gains that were estimated back then. In part because behavioral economics teaches us it takes about 20 to 30% of a group's think to evolve in order to start seeing benefits. And for example, with the ACOs, we've seen those spillover effects. When a patient panel is represented by 20 to 30% of patients who are in a risk-bearing model, we've seen benefits accrue to the commercial line of business and those patients where they might not be under a risk-bearing model. Similarly, with healthcare, the electronic health records took 5 to 10 years to implement. The average doctor works for about 40 years in the United States. And you play it out, it takes about 10 to 15 years to have that 20 to 30% threshold be reached. AI is different. Unlike electronic health records, which exist just in the silo of healthcare, AI is already infusing our everyday lives. For example, this past Christmas, we went on a trip, my wife and my family, to the national parks, and we used AI to map out our journey, saving 4 or 5 hours of our own time. And that usage is affecting the way people are using this already in healthcare and rapidly adopting it and being comfortable. It itself raises some ethical issues. So, for example, a doctor reached out and said, with the change in the algorithms allowing for paid advertisement, do I trust the output? And these are challenges we're going to have to tackle as AI becomes more embedded in everyday healthcare delivery. However, it does make us much more excited that $400 to $750 million could be accrued much faster than other technology revolutions in healthcare. And I look forward to talking more about this during the rest of this webinar.
It's really great to be here with all of you today. I am a practicing primary care pediatrician and also a patient with a chronic condition. This is a really exciting time in healthcare AI. It is completely transforming the landscape of what's possible, not only for clinicians and healthcare systems, but directly for patients. These AI tools are very empowering to not only help find out what may be going on about a particular treatment or diagnosis, but can also help patients be better prepared for their healthcare visits. And as a primary care pediatrician, I see this in my practice where patients come in and they may tell me that they're using an AI tool, and I really welcome that. I lean in, I ask them questions about what AI tools they're using, how they're using them, and I do warn them that there are real risks. We know AI tools hallucinate, and moreover, the way in which you prompt these tools can significantly change the outcome. And that's why we have a lot of evaluation frameworks, both from industry and academia, looking at how well AI tools are actually functioning in the real world for medicine. But the issue is that most of these AI evaluation frameworks that are out there don't involve patients in the process. They're largely clinician experts, technical scholars, legal experts who are evaluating how well specific AI tools do when clinicians may ask questions or have clinicians frame things in a certain way. But the way patients ask questions, interact with these tools is very different, very heterogeneous, and we need to involve them in the actual process of seeing how well these tools work and bring in their values. And I share my personal story to highlight how this fits in. I am someone who, as a child, my brain stopped communicating with my bladder, and as a result, had to have bladder surgery. One of the complications from that is that I am at risk of developing bladder stones, and have to have periodic imaging to take a look. This could be an ultrasound, an X-ray, a CT scan, a combination of them, and they all have different trade-offs. The ultrasound doesn't expose me to radiation, but it's not as good at finding smaller stones. The CT scan really good at finding everything, but it exposes me to a lot of radiation, and especially as someone who may be getting multiple images over my lifetime, that's something that I'm really cognizant of. However, a few years ago, when I was seeking out a new healthcare provider across the country, I was told I was going to be getting an ultrasound, but then at the last minute was switched to a CT scan. And I was concerned about this and started to advocate for myself because of the concerns of the radiation, and was also informed that at this particular healthcare facility, that the ultrasound costs significantly more than the CT scan. That may not be the same case at every institution, but I had to now weigh in real time all of these personal values. Did I want to pay more money to get less radiation exposure? But if I took this pathway, was it likely that something would be missed? And as a clinician, I had the knowledge to be able to sift through this information, but that's not the luxury that most patients may have. But AI tools have started to change that equation. They start to empower patients with answering all sorts of questions that fit in with their values. So it's really crucial when we think about the evaluation of AI tools and how well they work, that patient values are enshrined in the process, that patients are part of the whole process. And I think clinicians are a little bit concerned about the shift that AI is causing when patients start to use AI tools and come into healthcare visits with a lot of knowledge already. There are some clinicians who are concerned about the shift in autonomy and power, but I'm quite excited. I think this is a welcome change that really empowers patients. And I think that this actually creates the opportunity to build a more collaborative model where patients and clinicians have an elevated conversation because the AI helps to gather the basic information so that that human-to-human, face-to-face time is really focused on the details that truly matter. And so that's why we really need to make patients a core part of the process of how we build and evaluate AI tools in healthcare.
Last September, Zach invited me to participate in the RAISE symposium. RAISE stands for Responsible AI for Social and Ethical Healthcare. And that led to 3 days of meetings in Portland, Maine, and ultimately a paper published in January in the New England Journal of Medicine AI on making hidden values visible in clinical AI. And what was really striking in the conversation at the symposium was the report on research evaluating different AI systems. What we heard was when you query these different systems that are used to support clinical decision making, they actually offer widely divergent advice on how to handle clinical cases. So let me give you an example. This was an example we heard a lot about at the meeting in Portland. So consider a young woman hospitalized for cardiac complications of anorexia. Her weight is stable, but she refuses oral supplements and she declines a feeding tube. And the question asked of these AI systems was, should clinicians place a feeding tube against her will? And interestingly, the AI systems were split. Some said, yes, go ahead, place the feeding tube. Others said no, honor her refusal, watchful waiting. We made the case in the paper that when health plans choose which AI systems to adopt, when patients consider clinical recommendations generated with help from AI, they need to be able to see what values are baked into that AI model. So the paper proposes a labeling system to make that visible. What I'd like to do is throw out the suggestion that we should go further than that. Not just make encoded values visible, but get to the question of what values should be encoded as a normative matter. So, back on the anorexia case, one might argue the real question is not go, no go on the feeding tube. The question actually is first how to engage with the patient to determine her understanding of the options and their relative benefits and risks, to decide whether she's able or unable to fully engage and consider assessing, if it appears that she's unable, consider assessing her decisional capacity. And if the assessment yields the conclusion that she has lost decisional capacity or doesn't have it, then reach out to involve a surrogate decision maker. So what you get instead of go, no go is actually a process, a longitudinal process for understanding the patient's preferences, determining her decisional capacity if warranted, and reaching ultimately a decision grounded in those patients' values and her well-being. Okay, so now we've gone beyond just making whatever values are encoded visible to talking about what values actually should be encoded. But I'd like to go even further. So far, what we've been talking about is ethics, values, and substantive values alignment. But I'd like to argue there's another crucial element here, which is legal alignment. So the question also is whether respect for established legal rights, patient decisional rights, and required decisional processes, whether respect for all of that is or is not encoded in the AI tool. This is actually quite different from what you usually see discussed when people talk about the relationship of law and AI, where they talk about, is the AI system HIPAA compliant? Does it conform to federal and state rules? I'm talking about the AI system and what is baked into it. So in the anorexia case, one might argue that crucial is the question of whether the patient's decisional rights are being respected, whether the presumption of decisional capacity, absent assessment and determination of incapacity, is being respected, and whether required decisional processes are being pursued. If, to go back to the actual AI systems we heard about in Portland, if all you're getting is go, no go on the feeding tube, the answer to whether there's legal alignment is no, it's not there. And lack of legal alignment is a big problem. Law is one way that we write into our social contract how we agree to do things, including healthcare decision-making. American health law recognized patients' rights to make healthcare decisions, even against medical advice, starting in 1914 in the Schlöendorff case in New York. So it's been over a century of work to consolidate consensus about these fundamental rights. And an AI system that fails to encode those basic patients' rights and appropriate process will very predictably lead clinicians astray and undermine not only ethics, but also fundamental human rights. So making the values encoded into these AI tools visible is step one. It has to be part, I'm arguing, of a larger process of setting standards. These tools need to encode good science, appropriate clinical guidance, relevant ethics, and crucially, established legal rights and processes. Thank you.
Let's get right into the conversation. Nikhil, you were prescient in many publications, particularly around 2022, in seeing where was going to be the spend and the early impact and early implementations of AI in healthcare. And I'd like you to ask you to think of now, based on everything you're seeing, where is the play going to be happening about people putting their thumb on the scale in purchase of products or frameworks around AI to actually affect the spend of healthcare?
Great. Thank you for that question. A couple of things come to mind as we're looking at the landscape right now. First, people don't know what the end state is. We're seeing changes rapidly. Is money going to be taken into these algorithms and then affect the way that they run? So the end state itself of the way AI will operate is still in question, which does affect how fast adoption is happening and where it is being adopted. Second thing, though, is VC money is really flowing towards AI, especially in healthcare now. So as we are watching other things happen in the regulatory environment with the rate notice and those types of things, where is capital flowing? And there's a lot more capital flowing to AI vendors, which enables payers, providers, the like, to quickly adopt these in a way that may not have been there in the past. I think the third interesting fact, as I mentioned in my talk, is there's a bottom-up swell happening on this technology that hasn't happened in other technologies. When we implemented EHRs, that was it. You used your EHR in the hospital, you didn't use that in your real life. But the way people are using AI in their real life is actually creating a bottom-up swell amongst clinicians and frontline workers that hasn't happened, that is raising real questions of governance. Who's monitoring that? How's that changing from the top down versus the bottom up? And I think those factors, we're seeing value rapidly accrue. We're also seeing value destruction, to be blunt, because people aren't necessarily implementing the right way. We're doing this little use case. We're not thinking about the whole process redesign. But these governance issues and how this is going to play out in the end state, I think is still unknown, but the value opportunity is still there, Zach.
Great. And so, Jonathan, I'm going to ask you, thinking on behalf of yourself, to the extent you can speak for yourself, there's really a different approach being taken by different countries. I would caricature, for example, Europe as sort of locking down everything and, in some sense, in my opinion, perhaps precluding some of the benefits of AI prematurely. On the other hand, our current administration in the United States seems to be saying, let's hold off on regulation. How do you think it's going to play out in terms of who's going to mind the store at the highest level with regard to how these values get injected from these different parties who have a lot at stake in AI and clinical decision making?
Yeah, that's a fascinating question. I think America is well positioned to lead on this and innovate, as we have in many other prior examples. And so I remain optimistic there about the opportunities that lie ahead for us as a country. I do agree that there are different voices at the federal level, different stakeholders, and then of course we have a federal system, and states themselves have some levers that they can pull. And so we're very much aligned with what Nikhil said, which is we don't know where we're going yet and how this will all settle. But I think I would just point to the fact if we can get the incentives right, the data infrastructure right, and the regulatory oversight right, that this will be a huge win for us.
Do you see a particular, if you read the tea leaves, a particular near-term locus for the regulatory infrastructure, or is it too early to tell?
I think my optimism comes largely from my view that in the end, the market will demand good products. And so if this is creating value for patients, if it's creating value for providers, that eventually, despite the messiness of the process that we live in and sit in, the regulators and the incentives and the payers will figure out how to get it done.
Thank you. Susan, you've made a point throughout your career, at least the part of career I'm aware of, that we need to look out for patients and their utilities. And I remember back in the genomic heyday, you really were worrying about what were the effects of all these direct-to-consumer and other kinds of genomic resources being made available. At the same time, in my opinion, unlike perhaps some of the early overpromises of genomics, patients are benefiting from AI today because, among other things, they don't have access to primary care in a reasonable way. How do you think, what would you recommend? How do we get to a place where patients are actually protected? Is there a place for the law here?
Well, a couple of things, Zach. Great question. One is the journal just published a couple weeks ago a great article about how many clinicians are really using AI that is ungoverned in the healthcare space, and that we don't have effective governance. We don't even have effective visibility on what they're using and how they're using it. To protect patients, we got to fix that. I mean, if clinicians are just using, general purpose generative AI and we don't even know how, and it affects their recommendations to patients, that is a big problem for patients. So that's one issue. But the other issue, I think, is that as we make all that visible and query those systems and learn, well, how are clinicians in real life using this? What are their queries? And then how is it affecting decision making? We need to make sure that the AI that clinicians are using is aware of established patient decisional rights. Patient rights to make decisions, including decisions that are contrary to what the clinician recommends, has been established for over 100 years. I'm actually really worried that if we just have 1,000 flowers blooming and we have no visibility on how clinicians are really using these AI systems, and it turns out it's affecting their recommendations, that could really gut a century of progress on patients' rights.
Thank you. Well, you actually triggered a thought, which I'm going to now pass on to Chetan to think about. How do we know how clinicians are going to be using the AI? You are, involved in a lot of innovation in healthcare systems. How do you think we're going to be able to keep track of what's going on? What's the AI equivalent of post-marketing surveillance?
Yeah, I think, I think the number one word here is transparency. It's transparency between clinicians and healthcare systems in terms of what tools are being used, transparency between clinicians and patients. So I work, even this week, I was seeing patients in the primary care pediatric setting. We went through a number of hot topics, just had discussions with parents about what vaccines their child should get or not get. And I go into very transparent conversations with families of asking them, what AI tools are you using and what are you putting in there to kind of ask guided questions about whether or not you want to get your child the hepatitis B vaccine, especially as, we have the challenges of what the AI systems are bringing up, but now as authoritative bodies in terms of scientific medical consensus are also shifting, these AI tools are picking up on all of those as well. And I actually think that by bringing transparency in how AI tools are being used, definitely hear Susan's concern about, I think with unregulated, rogue, non-transparent AI use, there are real patient harms that can happen. But I think by bringing transparency between patients and clinicians in what AI tools patients are using, as well as the AI tools that clinicians are using, and making that more visible and talking about it among clinician colleagues, clinician to health system level, we start to have a more realistic understanding of the information that's being out there. And so I think transparency in the use of AI is really essential because everyone is using AI tools in clinical care, and we need to make sure we shine a light on that. So, because I think the other core challenge is that with generative AI tools, you get different answers every time. And so, bringing in that transparency can help to shed light on the differences that are coming up, even with multiple clinicians at a health system who are using a similar AI tool for a similar specialty question to make sure there's consistency in what these tools are outputting.
So, Becca, I think I'm going to try to appeal to all your hats here. Your hat as a lawyer, your hat as a psychiatrist, and also your hat now of leader of a medical society. Let's go, Chetan just said something that I think many doctors would be afraid to do because it creates an open-ended set of questions. What are you learning from AI about vaccines or so on? That's, I know a lot of doctors are somewhere between worried to, frankly, frustrated at how much time they have to spend sometimes on that conversation in a very small time window, sometimes when it's not exactly what they would agree with. And yet, I think what Chetan said is, I think, the future, but I'm not seeing where is leadership in medicine going to come from. Do you think our medical societies are going to regulate this? Our professional societies, our state? Where is the impetus going to come to tell us what is reasonable behavior in this new world by clinicians?
Yeah, thanks for that question, Zach. I think there's a couple different pieces of this. One of the things that we've really been remiss at looking at until very recently is sort of this sometimes implicit assumption we make as clinicians, as physicians, that when patients are thinking about their health, it's all happening in our consulting rooms, right? It's all happening when we're there. And now patients have access, it's a very good thing, right, to information that previously only lived in our journal reading rooms, that only physicians or experts had access to, right? Now, what used to be our main journal reading room in our own medical school library is a coffee shop, right? So we don't need that anymore, and people get the information. But we've really focused, when we think, even the work that we've done early on about responsible AI in medicine has really focused on discrete medical applications. And so much today, what we're talking about is really the vast and overwhelming amount of unregulated AI. So how does this come into what medical society should do and what we should do as physicians? Well, I think we're actually behind the times probably on our patients about this, because we've been so worried about patient safety, as we ought to be, right, in the context of how we're using AI in our clinical practices, that we're probably not as savvy about all the ways that AI can be used and misused, and the ways our patients are using AI. And we have a lot to learn. So I think this is really, the biggest place to start here is that the power imbalance that focused on the information differential from the beginning early on in medicine is actually pretty much shifted, which is great for patient empowerment, but it also carries risks of harms if we don't know what the sources of that information are. And this has got to be a partnership between the profession and the public and patient advocacy groups as well, in coming together to have a real conversation that's transparent and establishes trustworthiness as a team between AI tools, patients, and their physicians. And that's going to take a lot of work, and different kinds of work than we've been used to doing. So, when we write medical ethics opinions at the AMA, those are, the code speaks to physicians. And we need to be involved in a much, much broader conversation that doesn't just start and end with physicians and practice, but really starts starts and involves a major conversation and ends with doctors and patients and developers and AI systems and tools all in conversation with each other.
So I think that's a key point, which is, I think, partly why we're having this little meeting that we're just having right now, which is we need to have, as a society, that conversation. And that conversation is not really happening. And speaking of which, I think certainly if I pulled up a glass of scotch, it's afternoon, so that's just fine. If I pulled up a glass of scotch, I'd be ready to have 4 times the length of this conversation with you all about this. Unfortunately, we actually do care about our listeners and readers, and I am told that there are some people who have some questions that they'd like to pose. So let's listen to the powers that be, and let's hear from a very stentorian, mellifluous voice tell us what the questions might be.
You talked about predictive AI transforming drug development. So 2 questions. What will that mean for clinical trials? And will it lower prices?
Wow. Nikhil, let me give you, I'm going to ask the people who are the closest to economics about this. So Jonathan, heads up. So Nikhil, I'm going to give Jonathan and Nikhil a quick response. So Nikhil, first you.
So this is an interesting question. As we've started looking at this data, what predictive AI can help do is probably increase the probability of success for clinical trials. Can we do better pre-trial identification of different molecules and run them through the process? The question on price is interesting. Is there are some arguments that say the cost of the drug represents not just the cost of developing that drug before it comes to market, but also all the failed trials along the way. This is research that Tufts has done to say, what does it actually cost to develop a drug? If you would believe that these drugs are going to be higher probability of success, you would say, therefore, there are less failures, therefore less costs in the system. That's all nice to say in economic theory, but the reality of it is drug pricing is kind of separated from that based on the way that the system negotiates. So while it's probably clear that drug discovery and development will benefit from predictive AI in many ways, and I know pharma companies are trying to figure this out rapidly, it is unclear what it would do to prices, just given the varying incentives and the way the system works today. Jonathan, I don't know what you would add.
Yeah, I'd add a few things. I think that predictive AI will enhance our ability for more precise targeting and stratification based on risk and based on responsiveness. And my anticipation is that that will move us away from a typical blockbuster model that we've really experienced over the last 20 years toward much more bespoke kind of therapies. I think that has a couple implications for spending overall, and I think that the price implications are maybe more ambiguous. My expectation is that we should see a higher ROI because of this precision, where the value of treatment actually is better. Rather than having a shotgun, we have a laser beam kind of approach. I agree with you, Nikhil, where you landed in that conversation, that pricing is a function of value to the consumer, of course, and the patient, as well as the alternatives that are available in the market. So it's really dynamic, and it's hard to anticipate exactly how all those dynamics will play out. But I also would agree that those historical R&D costs actually are irrelevant at the end. A lot of times the conversation gets muddied around there. So let's separate kind of that part of it, which is important for how new therapies will be developed and how much R&D and capital will be poured into this versus where the market lands on prices. But certainly, I guess the final point I would make is prices are not equal to cost. We might actually see some cases here where the cost per treated patient comes down, yet total spending increases as we're able to treat people better with fewer side effects more effectively. In fact, I think we have a lot of examples of this in our system in the past.
Excellent. Thank you. And again, in the interest of public interest, let's hear the next question.
You've talked about evaluating AI in healthcare, the fact that it's usually medical, legal, technical experts, and that patients ought to be involved as well. What does evaluation look like today? How is it actually happening?
Chetan, take a whack at that.
Yeah, so evaluating AI tools, particularly generative AI tools, is a complicated matter because the model, the way you prompt the model, and all of the nuances where is it, a single turn of the model, or are you having a multi-step conversation, can yield different results. And these models are always changing. And so the evaluation frameworks initially started with more simple testing of looking at can these AI models pass the USMLE, the board exams, but getting to multiple choice answer questions is not that interesting in terms of the real world performance. And so we've seen a number of organizations, both from academia and industry, try to create benchmarks that get to more real clinical use cases in terms of how AI tools would actually be invoked. That being said, most of these benchmarks that are created often come together where there's a group of expert clinicians that are recruited, sometimes kind of beyond the clinicians. There are legal experts, other scholars who come up with cases, and then there is a certain framework that's used to then put different AI tools through those cases and come up with a benchmark score. But I think one of the big gaps that we're seeing is that works well for clinical facing AI tools, but we're increasingly seeing patients, the average person, use AI tools to ask medical questions, and we're seeing the big AI companies increasingly advertise that you can use them to ask health questions. But the way an average person or patient, and there's obviously a very heterogeneous group from someone who is a patient who's been living with cancer for many years, is really an expert in their diagnosis, oftentimes more so than an oncologist because they know they have that lived experience of living with their condition, may actually be able to use these AI tools in a very nuanced way. But to kind of illustrate this in a specific example, I saw a post from a person who took all of their cardiac information, their lab values, some recent notes from their cardiologist. They put it into an AI tool and they said, hey, give me a letter grade from A to E on my cardiac health score. That is not a standard medical cardiac algorithm, but that's something that patients are probably doing out there and maybe updating it over time. And they're saying, hey, according to this AI tool, my score just went from a C to a B plus. But that's not a medical grade evaluation metric, but this is what patients are doing. And so to close on this point, I think the evaluation frameworks, tools, metrics need to incorporate patients, people with lived experience, and obviously that's a very wide and heterogeneous group. But there are ways to do that. I work with organizations like the Open Notes and the Light Collective that are nonprofit organizations that really bring patient expertise to the creation and evaluation of AI tools. So we need more patients involved in the process.
So, Susan, unfortunately, I'm going to ask you to be brief because I want to make sure we have more questions. Answer this focused question. When I was a patient and not a doctor, which was many, many years ago, I could read a book, and the book would have some recommendations from me. Did I need to write an evaluation of the book? So do consumers need to have evaluation of these AI models? And
Sure.
why is it more than a book, evaluating a book?
I think a couple of reasons. There's we already know from research that there's a kind of automation bias that people kind of put their questions, their personal questions, into their phone or into some tool, and they're inclined to put a lot of weight on what they get back. They don't understand the cautions. They don't understand some of the points that Jason just articulated, that there are actually rigorous frameworks for evaluating your cardiac status, and that what you've just done with your phone isn't that. So I think figuring out how to make visible to patients the pros and cons, the dangers of what they're using, how to create some guardrails and visibility around that would be really useful.
Great. Thank you. So I think we might have time for one more question.
It's assumed that human in the loop is an important part of these AI tools. What does that mean to you? How big is that human presence? How big is the loop?
great question. And so, Becca, again, I'm going to lean on all your different hats. That's a bad metaphor. And ask you, I think it might be a generational thing. I'm not sure, but there is a subgroup of humans who are actually quite comfortable using AI as a therapist, and sometimes with good results, as we've published, and sometimes with very bad results, as we've heard also in the news. And what do you feel is the right approach with regard to human in the loop, both for doctor to AI interactions and AI to patient interactions?
Well, I think human in the loop, we use as shorthand for a lot of different things, right? So, you wrote on this early, but the idea of compared to what, right? So some of us use human in the loop to say, did the AI get it right from not from a technical standpoint or from a medical knowledge standpoint? And I think we feel pretty comfortable about that, but we ought not be necessarily so confident that we get it right, both for the reasons that Susan just mentioned in terms of automation bias and how we ourselves as physicians respond to technology, how patients respond to technology. And then there's another piece around human in the loop as something that's more uniquely human, about our values, about our empathy, about our relationality, that clearly we are seeing get lost in some of these examples of using unapproved, in particular, AI systems for mental health. So, where do we go with that? I think this actually requires us to do some pretty hard work about what it means to be a physician and what it means to have a relationship between a physician and a patient in an era where the informational power imbalance has radically shifted. The experiential power imbalance has also shifted in a very good way for patients really to be, as Chetan talks about, so clearly drivers of their own care and empowered in different kinds of ways, as Susan talked about, and the importance of patient autonomy and decision making. And so this is new territory. I think we don't really know what human in the loop is, and what it means. And it's something that we've got to figure out really soon, because otherwise the very nature of what it means to doctor, to take care of others, and what the profession is all about will escape us. And that would be both sad and scary.
Yeah, very good point. And I'm told by the powers that be that we still have a little bit more time. And I'll just add to what Becca said. For the first time, I'm really hearing sincere questions from our medical students about what does this mean for how I am going to be a doctor in the future. They really, it's not a matter of personal concern. They just don't know. It's lack of clarity. Let's get another question.
That's actually the next question. What's the role of AI in medical education, and what kinds of physicians are being turned out as a result?
Wow. I'll posit that no one really knows the answer to that. Since I'm very close to the medical students, I'll tell you that. But let's ask someone who sees a lot of medical students. Chetan, what do you think?
Yeah, I think it's a really profound question, and we're seeing this really play out quite rapidly. I've spent the past 15 years being really close to both myself being a trainee, but being close both in the West Coast and New York. For a lot of students who are close to technology and healthcare, but are still really excited about the practice of medicine. And I think we've seen such a rapid shift in such a short amount of time in terms of AI being able to handle more and more diagnostic capability. And we now have examples of companies that have the license to prescribe medication to patients without a human in the loop, right? So there is such a rapid shift happening in a short period of time. And I think from what I've observed, medical schools are still moving very slowly. I think there is a kind of shift to say, hey, how do we incorporate AI into making the existing education systems adapt more rapidly? But the actual practice of medicine is shifting much faster than I think education is keeping up with this at the moment. But I think overall, I'm optimistic of what the future looks like because I think, for a long time, medical schools have really selected for people who can remember a lot of things, have really great at memorizing information, less so about, necessarily the creative, human, artistic connection side. And there's this argument to be made that AI is way better than us at knowing all the details of every genetic mutation out there, and those are not things medical students and residents should be memorizing, but rather how does AI help to do more of that technical work and then elevate the human side of medicine to help both the clinician and the patient really connect at that level where care conversations are not just about data and information gathering, but are much more at that level of knowledge and wisdom, at that human to human connection. And I think we need to start to see that shift in the practice of medicine. I think there are risks that AI can automate care away and we lose the humanity. But I'm optimistic that AI can help us find the humanity in medicine, and medical education can actually maybe be more directed to supporting that.
So that was a very helpful response, because it leads me to ask first Jonathan and then Nikhil to use the breadth of their vision to inform us of the following. You triggered me by referring to some companies like Doctronic, which have enabled something that's pretty routinely done, namely prescription refills, to happen automatically and arguably more reliably than having a doctor's secretary refill the prescription. But there's a lot of companies that I'm really getting a feeling, not being plugged into business as some of you are, that there's just an upwelling of companies that are in this alternative space that's alternative to traditional institutional medicine, that is not visible actually to our medical students or to, in fact, people like me inside academic medical centers. So, Jonathan, what are you seeing, and do you think there's going to be some real innovation or disruption in the near to midterm around in this space?
I do, and I agree with everything Jathan said, so really appreciate also how he said it. So just full endorsement. And to launch from there, I've had long the contrarian view that the single best solution to what ails the U.S. healthcare system is to train more providers. And we've seen the market and states undertake a number of efforts to do that, whether it's top of license, greater supply of nurse practitioners, physician assistants, and so on and so forth. I still think we need more humans and more doctors, especially trained. But I think I'm more optimistic that actually these kind of tools that we've been talking will really help alleviate some of the supply restraints, and we are going to unleash better access, better quality, more competition across a number of ways. So I'm really excited about where this is going.
Thank you. And Nikhil, I've heard in my many years the establishment telling us how we were going to create more primary care doctors. We didn't. And by the way, just a reminder, in Boston, Massachusetts, residents in our hospitals in training do not have primary care doctors. And I've also heard about that we're going to fill the gap with nurse practitioners and physician assistants. And I think we're certainly trying, but it's incomplete. What are you seeing about, and given that gap, are you seeing that AI is that there's a credible move in that direction? And how does it play with medicine?
Look, I think it's going to be an evolution. One of my favorite things that actually comes from the automotive industry is they preset a level of automation from 0 to 5. 0, 1, 2 requires human intervention. 3, 4, 5 requires technology. It's technology led, and the human can be in the loop. And I think when we think about something like claims processing, Zach, that should be on the tech-led side. And a human might check it, and you might quality check it and do that. But something like clinical decision-making probably stays as human in the lead, and we talked about how technology can be part of the team. And so will this affect and change the way physicians operate? Absolutely. Which parts of what is going to change, I think we need to do. And I think part of what we say, oh, AI is coming, we talk past each other because someone's thinking of claims processing and someone's thinking of clinical decision making. And using that framework from the automotive industry, we did in our paper and we applied it to healthcare. It could just help nuance this. And then to what Jonathan just said, there is a physician shortage. How much of it can be tackled through AI versus what can't be tackled or AI could support? And then we can just break down the math problem and see where we are.
Yeah, I'm always amused when with really great answers like that, which sort of an inversion of the old saw that AI was going to replace doctors. And the real question is, we don't have the doctors. What is AI going to do to help us? I think we have time for at least one more question.
I'm a patient visiting my doctor. What would you suggest I ask about AI?
Holy smokes. Becca.
Well, I would say that it's important for patients to ask doctors. It's also important for doctors to ask patients, right? So that would be my take home point about this. But I think it would be reasonable for both patients and doctors to take the responsibility of asking, how is AI being used in my care? And that's not a negative question. That's actually a positive question, right? Because we know we make errors predictably. We know we're not perfect. And we know that automating certain processes, even checklists, right? Just a checklist helps us do better at our work. And so having a real conversation about what that means and how that can help the patient and what the physician knows is really opening up a conversation. So as long as we're really clear that as physicians, we're listening to patients and we're encouraging patients to bring those questions and to help us learn how to be better doctors and more responsive physicians as well. I think that just asking any question and opening up the conversation is a really great start.
Zach, if I could just add on to that for 1 sec. I think the problem is if the patient asks the doc, how is AI being used in my care, the doc faces a choice. Do I just disclose the sanctioned AI that my health system has said is cool, I can use that? Or do I really go whole hog and tell the patient flat out about the other AI? That I've checked some stuff on my phone. That's why I think it's so important to bring all of it into the light, particularly with this younger generation of up and coming med students who use AI all the time.
All the time. And that is the great way to end this wonderful conversation. And so now it's time for a closing comment.
For more information about events by NEJM Group, please visit events.nejm.org. Thank you for participating today.